For the gynecology case list, categories, again, there's multiple surgical or diagnosed-based categories such as abnormal uterine bleeding or laparotomy, and there's 4-column organization. It starts with a diagnosis, preoperative and admission diagnosis, the treatment, surgical pathology, and the complications. Anytime that you hear me repeat things over and over again, this is a really key point. So I'm going to reiterate it again. The surgical pathology needs to be organized. So that's one thing that we'll show on the next step. The first step, plan the format, organize patients by section. Abnormal uterine bleeding is the first category. Again, place cases in the best categories. So you might have a patient with abnormal uterine bleeding with also a fibroid that went into, you did a laparotomy on. You have 3 different columns you can place this patient in, but place the patient in the best category. The second step, again, summarize each patient. When you do the preoperative summary, that's what's on your operative note. So if I write symptomatic myomatous uterus, that should, as my preoperative reason for doing the hysterectomy, that's what should be on my preoperative diagnosis on my case list. Only what's done in the OR and post-op are really going to be in the treatment column. Sometimes what I see is patients put endometrial biopsy on there, and I think if you want to write that the patient had a benign endometrial biopsy preoperatively, I do that too when I'm doing my ablations, for example. I write preoperative, preoperative unsuccessful medical management, negative endometrial biopsy, negative pap smear is my pre-op diagnosis for someone doing an ablation. And I think it's more appropriate to put something you did in the office actually in the preoperative than in the treatment column. And then also complications. Did they have a readmission? Did they have a blood transfusion? Did they have any intraoperative injuries? Those should also be in the complication column. And then third steps, think like an examiner. Has the candidate demonstrated the standard of care? What questions does this case list raise about this and related subjects? And I put a little star right here, must put in the size of ovarian cyst, and that's a given on the exam.
So let me ask, going up to the complications that you just mentioned in the second steps section, there's actually within the gynecology category a post-operative complications like hemorrhage, wound infection, UTI, VTE, etc. When it comes to putting patients into the best categories and what they best illustrate or what you want to lead the examiner to ask you, things you want to discuss, I guess my question would be, how do you decide then which patients to put separately, say, into a post-operative complications category and those who would be like in your abdominal hysterectomy category, but that patient ended up having, say, a cuff cellulitis?
So I think personally, someone with a cuff cellulitis would be a great patient to place in the complication category. The other really great patients to place in there is someone who's had a PE, because those are good topics to talk about in complications. Intraoperative complications can go in that category. But I wouldn't, if you had, say, a case list of 100 patients and you had 8 surgical complications, I wouldn't necessarily put all the complications in that one category, but I would have a few representative cases from the case list. Third question, third step, think like an examiner. Has a candidate demonstrated the standard of care? So let's go and look at the next case list. So here's a case list before and after. You can see right here it says diagnosis, preoperative, or admission. And this is a great, it says abnormal uterine bleeding, family history of ovarian cancer. As an examiner, I'm going to be interested in this topic because here's a patient who's age 49 who had a BSO, who has a family history of ovarian cancer. that can lead to some questions on BRCA1, 2, or Lynch syndrome. The other thing I really like about this case list is you can see you have the grams and then the uterus, and then you list different things out. So I'm just going to tab through here. I think this is great the way that it was presented, but I would have presented it this way. Okay, so uterus, 345 grams, indent 1 space, leiomyomata, indent 1 space, left ovary, fibroma, and then I can say fallopian tubes benign. But I like the way I've done it because it takes more of the words out and still gives the same information.
Yeah, and it's a little more succinct, going back to that summarize and simplify kind of idea we alluded to earlier.
Right, and one thing that people need to know is the examiners really take a week of their life and to get us board certified. And anything we can do to make their lives easier in reading a case list, I think everyone should think about that when they make their case list up, because they get a certain number of case lists the night before and they have to go through things. And if things are very wordy, I think it makes it a little bit more difficult for an examiner to really read through this. On patient number 2, here's pelvic pain, endometriosis. I put in here unsuccessful medical therapy because I want the examiner to know I've tried to exhaust all conservative therapy on a 39-year-old before I decided to do a hysterectomy on her. Now, one thing that's interesting on this case list is what's missing, Patrick. What did we leave behind? What did we not take out here?
The ovaries.
Right. See, I got you on that one. So if I was an examiner, I would say, geez, this patient's 39. She has endometriosis. Why weren't the ovaries removed? Because if you have endometriosis and you leave ovaries in, there's an increased risk of recurrence. So this is a good topic to study and to really get into the endometriosis practice bulletin and to look at those percentages. So that's something that I thought of here. I put lysis of adhesions here. There. On question 3, family history of ovarian cancer, I put negative BRCA here. And then on question 4, she has endometriosis, again, unsuccessful medical therapy. Again, this person too, you can see, was fairly young and did not have her ovaries out. So I know that's something that I'd probably want to ask the candidate. And then on patient number 5, you said abnormal uterine bleeding here, but you say cervical dysplasia. I would actually want to know what type of pap it was. Okay, and it says cervix with SYN3. So if I were an examiner, one thing I would be interested in is, did this person have a preoperative LEEP or cone?
Absolutely. So that would be my question, because, for instance, you mentioned in case 1 or 3, perhaps, with the family history of ovarian cancer, specifically saying whether they had genetics, if they did negative BRCA testing. Is that a good idea, or is it better to leave it sort of open and see where it might lead, or should you be specific? Because some of us might, specifically those who don't have all that much of an interest in gynecologic oncology topics, maybe don't want to start talking about BRCA for fear that it will lead to discussions about Lynch syndrome and other familial inherited cancer syndromes.
Well, I can tell you, if I was an examiner and I didn't ask the candidate about BRCA1, 2, or Lynch syndrome, I would think that I would find it hard to believe they wouldn't get asked during the case list on that. Now we have so much more information with OVA1 and different and CA125. I really think the GYN-onc topics come up on the case of the days, and they come up on the case list. So I think if you leave it off, he's still going to get asked. So I like candidates to put it on, because as an examiner, I would want to know that question. It would help me figure out if they were positive BRCA. I wouldn't want to see this on a generalist case list. I would hope if she was positive BRCA that she would have a GYN-onc and pelvic washings were done. So It's kind of plus or minus, and of course these are all my own opinions. I don't represent anybody other than myself, but I like to put negative BRCA or negative Lynch syndrome in there.
Is it better to be as specific as possible, or not so simple, to be able to say be general with a term like cervical dysplasia, or be always specific with a term like cervical dysplasia, which could be broken down further into CIN 1, 2, or 3, or whatnot?
This all goes back to reading the bulletin. If you read the bulletin, the most important thing is you need to show the standard of care. So the way I interpret that bulletin is I think that ABOG wants me to put high-grade SIL, colposcopy SIN 3, LEAP, SIN 3. So I would think being more specific would be helpful.
Okay.
Here's my favorite example here, and here is abdominal hysterectomies, and here's an office case list here. One thing I'd like to show people is I have on my abdominal hysterectomy section, I have a supracervical hysterectomy, I have a TAH, and then I have a supracervical hysterectomy BSO. Okay? And one of the things I like to compare and contrast is the first case here is both of these uteruses are large. I did not have a morcellator in this case, and these uteruses were too big to do a vaginal hysterectomy. And my preference is not to do a supracervical hysterectomy. However, in this particular case, this lady had morbid obesity, and it was rather difficult, so that's why it was converted. So I put that case first because to me, that was something that was important for me to differentiate why I managed two uteruses with the same pathology with a different surgery. And then in case 3 here, not only did I do a supracervical hysterectomy, but I also did a BSO on a patient that was 52. And why did I do a supracervical hysterectomy in this case? I actually had a pelvic mass that was 11 centimeters that was almost within the cervical area, and it made it more difficult to do to take out the cervix, and so I put that in there. So this is an example of compare and contrast. On the right side here, I have 2 cases, case 11 and 12 from my office case list. And one thing I really like on here is these patients both, I did generalize urinary incontinence, so I'm pretty general here and here. But in the next column, I do history and physical exam, and when I'm doing my systometrics, one has stress and one has mixed, and they're managed differently. One gets an anticholinergic and one gets pelvic muscle exercises and topical estrogen. And this person obviously was a person that I discussed about pessary or a TVT in upcoming visits. So this is an example here of comparing and contrasting. So one thing about the case list is it does represent 50% of the exam. So this is the front of www.passingyourobgynboards.com. The number to call to talk to me at any time is 470-ACE-TEST. Also, my email is passingyouroBGYNboards@gmail.com. I have a lot of different ideas about study that I've put into my blog section. There's lots of different services that I offer, but my big goal is to give you today a little bit of an information of how to best organize your case list and to really steer you into an area of comfort with your case list submission. One thing that's very important is once you make your case list is to make sure that you properly prepare for the case list portion of your test. And that should be done starting a couple of months after case list submission. And that's a new topic that we'll talk on a future webinar.